Sandler, Stern Aegis Ventures, The Church of Jesus Christ of Latter-day Saints, Cryoport, Dr. Randall Prost, the Susan Scott Foundation, Amicus Therapeutics, Arlene and Martin Bednar, Healthscape Advisors, Malik's Pizza Palace, Selective Benefits Group, and the Sovereign Order of Malta, and those donors who wish to stay anonymous. We are here today because of their generosity. We also appreciate your help extending the dialogue by using your social media channels to share the highlights of the conference under the hashtags Unite to Prevent and Unite to Cure. Please remember to tag us at Cura FDN on Twitter, Instagram, and LinkedIn, and also on Facebook at the Cura Foundation. I also want to thank His Eminence Cardinal Gianfranco Ravasi, President of the Pontifical Council for Culture, for his unwavering support since our first International Vatican Conference over a decade ago. He has been a catalyst for the powerful interface between science and faith, creating collaborations that can help us advance human health and preserve our humanity, our culture, and society. And now, please welcome His Eminence, Cardinal Ravasi.
Sulla soglia e in apertura di questo importante e imponente convegno, desidero rivolgere il mio saluto a nome del dicastero che presiedo. È il Ministero della Cultura del Vaticano, della Santa Sede, che ha come compito quello di entrare in dialogo con le culture contemporanee, con l'orizzonte nel quale noi ci troviamo. Questo saluto è rivolto in maniera particolare a tutti coloro che seguiranno in queste 3 giornate i più di 100 relatori che cercheranno in qualche modo di presentare da angolature diverse i temi che sono al centro di questo incontro. Con me salutano tutti, soprattutto gli studenti che parteciperanno e che ascolteranno questo itinerario, che seguiranno questo itinerario, con me la Fondazione STOC, il cui acronimo significa Science, Theology and Ontological Quest, cioè scienza, teologia e filosofia, che si incontrano tra di loro e cercano in qualche modo di scavare, di approfondire alcuni temi che sono fondamentali soprattutto per l'antropologia, che sono fondamentali cioè per il nostro essere ed esistere. Un saluto particolare va anche alla Cura Foundation, che è stata con noi l'artefice di questo evento in tutte le sue sfaccettature. A questo punto il viaggio dovrebbe iniziare. In realtà si tratta di un vero e proprio percorso che è iniziato molti anni fa. Questo infatti è il 5° convegno che viene sviluppato attorno a temi sempre diversi, però appartenenti sempre all'orizzonte della medicina, della salute, dell'etica, della filosofia e anche della teologia. La scelta dei temi è affidata a una sorta di triade. Sono un po' come 3 stelle che si accendono nel cielo, qualche volta oscuro, dobbiamo dire, della nostra contemporaneità, della modernità, e che toccano alcune componenti radicali, fondamentali della figura umana, della persona umana. Innanzitutto, come è facile intuire, una presenza fondamentale ha il corpo, la corporeità meglio, cioè questa struttura, questa componente che non è soltanto biologica o fisiologica, perché noi sappiamo bene che noi non abbiamo un corpo, noi siamo un corpo. Anche in questo momento, sia pure attraverso questa via a cui siamo stati costretti dalla pandemia, che è la via della comunicazione informatica online, ebbene anche in questo momento il corpo risulta decisivo Le mie labbra, i vostri occhi sono pur sempre fondamentali perché scocchi la scintilla del dialogo. Il corpo è quindi una realtà fondamentale dell'esistenza umana, della comunicazione umana. Ed è proprio anche nella sua fragilità che verrà studiata durante questi giorni attraverso voci qualche volta anche di altissimo profilo scientifico, ma anche attraverso la testimonianza di molte persone che si interessano di questa realtà da angolature, da prospettive diverse. Un grande poeta americano come Walt Whitman, nell'interno della sua opera più famosa, Foglie d'erba, queste poesie essenziali e fondamentali, ha definito il corpo come in assoluto la realtà più sacra che noi abbiamo. E questo può sembrare paradossale, ma non lo è nel cristianesimo, perché ad esempio nel cristianesimo il mistero centrale della fede cristiana, in tutte le sue denominazioni ed espressioni, è l'incarnazione, cioè il verbo, il logos, come dice il Vangelo di Giovanni, la divinità eterna, infinita, perfetta, diventa carne, e carne è appunto la corporeità, è la storia anche nella quale noi siamo immersi. La seconda categoria, la seconda stella che idealmente si accende in questo convegno è in parallelo, dovremmo dire subito, l'anima. L'anima che nella visione dell'antica classicità greco-romana era in opposizione al corpo. In realtà noi sappiamo bene che già quella stessa antica cultura greca aveva tentato di stabilire un collegamento attraverso un famoso filosofo Aristotele, così come il suo discepolo, il suo maestro aveva cercato di scindere questo legame tra corpo e anima. Questo grande filosofo Aristotele aveva cercato invece di stabilire un connubio, un intreccio, un abbraccio tra le due realtà. Ebbene, l'anima, noi sappiamo, è la coscienza, è l'identità personale, è l'autocoscienza, è anche la sorgente della tendenza al desiderio di essere verso l'eterno e l'infinito, verso l'oltre, cioè verso la trascendenza. Ed eccoci allora all'ultimo elemento, la mente che è quasi il ponte tra queste due realtà. Noi sappiamo che la mente non è solo, almeno nella visione che noi, culturale, che vogliamo sviluppare, non è soltanto il cervello, cioè la struttura neuronale straordinaria che è nell'interno della nostra scatola cranica, questi 80-100 miliardi di neuroni, che sono tante quante le stelle della Via Lattea, della nostra galassia, il che vuol dire cioè un vero e proprio microcosmo che è dentro di noi in questo spazio limitato. Ebbene, noi sappiamo che il cervello, il sistema neuronale, secondo una visione culturale e religiosa diffusa, non esaurisce le potenzialità spirituali, non riesce a descrivere totalmente la mente, che è qualcosa di più. E qui la discussione sarà complessa, ma certamente significativa, non per negare o per affermare soltanto qualche aspetto, l'uno o l'altro, ma cercare di integrarli e di metterli in dialogo tra di loro. Queste erano le 3 stelle di questo incontro, di questo convegno, a cui auguriamo un successo molto intenso, perché sarà un grande contributo soprattutto a quella categoria fondamentale che sta alla base di tutto questo evento e di tutti gli eventi che cerchiamo anche come Chiesa Cattolica ora di condurre sulla scia del messaggio di Papa Francesco, che alla fine lascerà anche lui la sua voce, entrerà anche lui con la sua presenza in questo convegno, cioè il dialogo, l'incontro di visioni che sono diverse, lo sentirete. Ci saranno delle voci tra loro distanti, ma tutte si incontreranno nel desiderio della ricerca. Perché, e concludo ricorrendo a due grandi culture, la cultura cristiana, la cultura biblica ebraico-cristiana, e alla cultura greca. La cultura classica ci diceva che una vita senza ricerca non merita di essere vissuta. Così Socrate, il grande maestro di Platone, il filosofo che abbiamo prima ricordato, e la Bibbia che ci dice che ecco in una preghiera, in un salmo, in un'invocazione, tu, o Signore, mi hai fatto veramente come un prodigio. La creatura umana è quasi come il più grande miracolo.
We are honored to have with us Dr. Anthony Fauci, the director of the National Institute of Allergy and Infectious Diseases. He sits down with CNN's award-winning chief medical correspondent and neurosurgeon, Dr. Sanjay Gupta.
For more than a year now, Dr. Anthony Fauci has been helping all of us here in the United States, around the world, get through this coronavirus pandemic. His steadfast approach, full of evidence and facts, has provided a sense of reassurance, but also helped us develop things like vaccines at unprecedented rates, which have obviously been helping countries all over the world. Dr. Anthony Fauci joins us now. Welcome, sir.
Thank you, Sanjay. Good to be with you.
You know, I want to ask you a question this morning that I'm not sure we've really talked about. And you and I have had many conversations. Sometimes, Dr. Fauci, science and faith can seem somewhat incompatible. Faith, you're believing in certain things, but with science, you want the evidence, you want the reason, the judgment. Just curious, how do you think about science and faith and the inflection points, but also when something is truly novel, as the case with this coronavirus, there isn't a lot of evidence. How much do you have to rely on just your own faith, not necessarily religious faith, but just your system of beliefs?
Well, I think you have to rely on it when you're starting with nothing, Sanjay, almost completely. And it's sort of an interesting dynamic process of as evidence accrues and you get more and more information, then you have that transition from what your instinct and judgment, you know, it's very interesting when you use the word faith, and I'm glad you said not necessarily religious faith. It really is a combination of instinct, good judgment, and calling back from experience. That, you know, in some respects is a non-religious faith issue, that as you get further and further and more solid scientific information becomes available, you pull away a bit from the kind of experience, instinct, and get more into what the reality of the evidence that you have. You know, and that's an interesting thing because it explains a lot about when we're going through a very difficult situation like the evolution of an outbreak, people who don't appreciate that evolution of understanding and evolution of knowledge, that you're going to change some of your viewpoints because the data itself will not necessarily change, but additional data changes the status of your knowledge. And your knowledge may go from minimal and you're acting on, quote, faith, as it were, versus the true substantive evidence and data, which really gives you a much greater foundation. So that's the way I look at it.
I think it's really interesting. And I think when someone like you've been in this position for 40 years, you have a lot of pre-existing knowledge and you're going to instinctually, you know, just know things or be able to connect dots maybe in different ways just from that. That is what experience and judgment gives you. But how do you also allow yourself to be surprised, right? Because you're dealing with a virus, in this case, a novel coronavirus. But then some piece of data comes out that doesn't make sense. How willing are you to accept that sort of new data?
Well, that's a great question, Sanjay. And you must be flexible. I've said this so many times, flexible, open-minded, and humble to know that even though you have 40 years of experience, that when you're dealing with something that is really in the realm of the unknown, you've got to expect the unexpected. I mean, that's some of the dictums that I go by. Always expect the unexpected, particularly when you're dealing with a microorganism, which in many respects, from an evolutionary standpoint, has the capability to adapt itself to always survive. And organisms are not static things. And that's the reason why we're seeing the evolution of these variants. If it was a static situation, you would know exactly what it was right from the beginning, but it continues to evolve. I mean, I think one of the real good examples of that is that the dictum of infectious diseases forever were that respiratory-borne viruses tend to have a very small amount of transmission from an asymptomatic person. The thing that drives respiratory illnesses are fundamentally symptomatic people. And we know that influenza and other types of infections have a small fraction of maybe 24 hours before a person gets symptomatic that they can transmit it. We never would have imagined, and it was unique, that we were dealing with a virus where 1/3 to 40% of the people never get any symptoms, and 50 to 60% of the people who get infected from someone with no symptoms. That was completely unprecedented, totally. And that's the reason why when scientists were saying, it's not really a major driver, asymptomatic infection. And now you find out that it is at least half of the infections are transmitted. The reason why that's important, it impacts everything that you've been sort of like going by. It impacts the ability to do identification, isolation, contact tracing. It impacts the profound need to wear masks. When you say, well, I don't worry, if I don't feel sick, why should I wear a mask? Now we know that you could be spreading the virus. So that's what I mean by using your experience, using your knowledge, but always keep an open mind that you're going to find out data. They're going to have you change some of the things that may have been foundations of what you've done for years.
I'm curious, and I don't know how you would frame this, but if 100% is all of the knowledge that exists about a particular thing, in this case, the virus, where are we right now? I mean, how much do we know about this virus? How much do you think is still left to learn?
Oh, I think that there's a substantial amount, not only about the virus, what the virus can do, but the pathogenesis of the disease, the thing that, if I have the opportunity sometime to be able to slow down and get the lab to look at things, I want to find out, how could it possibly be that the same virus that's killed 570,000 people in this country is a virus in which more than half the people don't ever get any symptoms? I mean, you could say, well, they're young, they're healthy, but that's not an adequate explanation. There's something there, something that we don't know about the pathogenesis. The other thing that we don't know about is the ability, how extensive is the ability of this virus, if you don't really suppress it completely, to develop new variants. And every single week, Sanjay, that goes by, we get hit with another challenge. First it was the 614, first it was the Wuhan strain. Right. Then we said, wait a minute, we have a 614 now. Okay, so that's one variant. And then all of a sudden, the 351 in South Africa, and then the 117 in England, and now the 617 in India. It's like, it's a wily opponent. It's a wily opponent.
How worried should we be in the rest of the world about what's happening in India? Is that a cautionary tale?
Well, it's a cautionary tale from so many standpoints. I've seen this with HIV in a less dramatic way, where individual countries say it will never come here. We don't have the conditions for that to happen. You know, when India had that first blip and then it went back down, and then we saw doing the ceremonial feast at the Ganges River. When I saw that on TV, when you showed that a week or so ago, Sanjay, my heart sank. I said, oh my goodness, that is going to turn out to be something not good. And that's exactly what happened.
I'm curious, Dr. Fauci, in the minute or so we have remaining, going back to just this inflection point between science and faith. There's a lot of vaccine hesitancy in the world. You know, we see around a quarter, 20 to 25% in the United States. To some extent, people need to believe, based on the evidence and the facts and the data, that this is a good thing to do, that it's going to help them protect them and make them less likely to transmit the virus. What do you say to people right now, maybe even friends of yours, I don't know, who are vaccine hesitant?
Well, you've got to connect them with people they trust. The thing that we're finding out, that it depends, you have who is the audience and who is the messenger. You've got to match the messenger with the audience. And I think if you do that, you're going to overcome a lot of the hesitancy. When you go into the trenches, and you have someone who's a deeply religious person who will listen to their clergy, that's different than me with a suit going into an area telling people to do something.
I think most people would listen to you, though, Dr. Fauci. I'm just putting it out there, you know. And thank you very much for your time. One of my great aspirations, dreams, is that we get to spend some time together in person in the next several months. So hopefully we get to do that.
I not only hope, I'm going to make sure it happens.
Dr. Fauci, thank you for your time.
Thank you, Sanjay. Good to be with you.
You too.
Our conversation on shaping the future of healthcare for a healthier world features Dr. David Feinberg, head of Google Health, and Dr. Mark McClellan, who is both a business professor and director of the Duke Robert J. Margolis Center for Health Policy at Duke University. They are interviewed by Dr. Stephen Klasko, CEO of Jefferson Health.
I am thrilled to be here today. And I think one of the things that really makes this conference special is bringing stakeholders from all sorts of different industries together, and also that we don't mind asking the really tough and bold questions. And I think we've achieved both of those with this panel, with Dr. Mark McClellan and Dr. David Feinberg, bringing health policy, big tech, but all of us share the view that disruption needs to happen in a positive way. So I'm going to start with the most difficult question first, so the rest will be easy. So Mark, despite the ACA, CMS changes, some of which you've been responsible for, and David, despite the incredible amount of capital that's being invested in digital transformation, of which, David, you're working on very well with Google, so much of which, whether it be telehealth or online education, was not available to 20% of Philadelphians in my area who didn't have broadband. How do we move health policy, and those of you responsible for the fourth industrial revolution, to create an environment of, let's call it, universal connectivity, and be sure that we're not creating a new generation of virtually or technologically homeless group of underserved patients? How do we ensure that your zip code is not the most important component of healthcare outcomes? An easy question to start, and either one of you can go ahead.
Well, first of all, it's great to be here and to be with both of you. Let me push back, Steve. I think actually your zip code is the most important determinant of your health. So what's happening in your community is as important as your genetic code. And so access to food, understanding where housing is, understanding medical information in a way that makes sense to you is super important. So for us, it really is about organizing the world's information and making it useful and accessible. So when we think about things like COVID, for example, which I'm sure we'll get into, we have had 400 billion views of our COVID information page on YouTube. So that reaches wide audiences. The other thing that you mentioned around broadband, you know, there's really the next billion users we think that are coming onto a mobile platform where smartphones will become much more common than they already are. And as those folks come on, what can we do to make sure that they can get the right information on their phones in a way that's mobile that does what you're asking in your question and help equalize ability to access care, high quality care, and affordable care.
Just to pick up on David's comments, first of all, I too am really glad to be part of this unique dialogue. And zip code is a proxy for things that really matter for health, what your living conditions are like, what the risk factors in your environment are like, whether there's an easy place for you to exercise, and access to healthcare is a piece of that. Hopefully with the more detailed data and capabilities that are coming to act on that data for individuals, we'll be able to translate what looks like a hard thing to really transform a zip code into something completely different, into ways to make progress on that. There is increased attention driven by digital capabilities to be able to reach people where they are in their homes, as we saw happen during the pandemic, and to connect them to a broader range of resources to help improve their health. Not just scheduling a visit with a doctor, but figuring out if they're feeling isolated and mood issues or behavioral health needs could be met, figuring out if there are other social service needs, food insecurity, housing insecurity, and helping to connect that. Unfortunately, as you say, we don't have as much data connectivity as we'd like to support that. And I think one of the most important changes in healthcare that can help make that happen is to set up our payments and our other policies in a way that reinforce caring for the individual where they are at home, and not just paying for services that are often downstream and not really going to get at those core issues that are embodied in your zip code.
Mark, let me follow up on that, because one of my mentors, Bill Kissick, when I was at Wharton, wrote a book called Medicine's Dilemmas, Infinite Needs, Finite Resources. That was about 40 years ago. And he talked about the iron triangle of access, quality, and cost. And he said, if you increase one item, you get an decrease another. If anybody says you're going to increase access, increase quality, and decrease cost, and it's not going to be disruptive and painful, they're not telling the truth. So if you think about the ACA, there was a lot of, good news, we're going to increase access, increase quality, decrease cost, it won't be painful. I think in our country, President Trump said, it's going to be terrific, fantastic, unbelievable, and huge, and it really wasn't any of those things. So how do we make sure that we're not just giving more people access? What can government do, not just giving more people access to a broken, fragmented, expensive, and inequitable system and hoping we'll transform? So you ran the CMS. What are the biggest obstacles to achieve that brass ring of sort of wider adoptions of all the things you're talking about, efficiencies and value-based care?
Well, one thing that is special in our time, as opposed to that, you're right, that iron triangle of cost, quality, and access has been around for a while. But one thing that we've seen consistently happen over the last 40 years, Democratic, Republican administrations, actually in the US and elsewhere around the world, is increased spending. And for a long time, for basically 1970, 1980 through the 2010 period, that was associated with improvements in outcomes, not just for wealthy individuals, but for lower income populations, Black and brown Americans, minority populations here and elsewhere in the world. That had started to change before the pandemic, where we're seeing a leveling off of improvements in cardiovascular mortality, an increase in so-called deaths of despair from substance abuse, violence, and suicide. And as a result, even before the pandemic, life expectancy in the US was falling. And with the pandemic, with a disproportionate impact on Black and brown Americans, we've seen a loss of the gains in life expectancy the last 2 decades for Black Americans, for example, and decreases in life expectancy overall. So we have more clear evidence now than ever before that it's not just a matter of putting more into healthcare that makes a difference. We need to put more into healthcare, like we were just talking about a minute ago, that meets people where they are, that uses digital technologies and other innovations like care teams and things that you're doing at Jefferson, Steve, to change the way that care is delivered. If we don't do that, if we don't sort of broaden the lens for care delivery to support digital health and these other innovations, I don't see those trends turning around.
Thanks, David. We've been friends and colleagues for a long time. You moved from the traditional healthcare ecosystem, doing a great job both in California and Pennsylvania. And now you're leading Google Health, and Google's transformed so much of our life. We spend almost $4 trillion a year in healthcare, most of it, as Mark said, for treating diseases and sick care, not necessarily preventing them. So and you mentioned before a lot about data, all the data you're aggregating. I've often said we don't have a problem with not having enough data. It's just we have a problem with what we do with that data. So how do you see AI and machine learning transitioning us to healthcare that's truly predictive, preventive, and outcome-based, which is what Mark talks about all the time in health policy?
Yeah, so let me give a couple examples, one kind of in the inpatient setting and one more from a community standpoint. So from the inpatient setting, our team in London came up with an app, really, really simple. So the rapid response team, the team in the hospital, gets called when a patient's starting to go into kidney failure. And the only thing the app did was tell you if creatinine went up, which is a measure of kidney function. Okay, that's it. Creatinine goes up. We saw a 30% less folks had cardiac arrest. Cost of care went down 14%, and time to diagnosis, 17%, and time to diagnosis goes from 4 hours to 14 minutes. Okay, so that's great. Then we say, well, instead of looking at creatinine, let's do AI. So partnership with the VA, we look at 600,000 variables per patient in real time through their EHR. Now time to diagnosis goes from not 4 hours to 14 minutes, but -2 days. So 48 hours before anything happens clinically, we can tell you with 90% accuracy, this patient who has no clinical signs is going to be on dialysis. Like, it's fundamentally changing the sense of anticipatory medicine. So that's predictive. We can do the same with mammography. We can do the same when we look in the backs of folks' eyes for diabetic retinopathy. Not only can we reach specialty level performance, there's novel signals in there that none of us learned in med school. We can tell your hemoglobin A1C. We can tell your age by looking in the back of your eye. So that's in the medical side. But when we start talking on the consumer side or on the clinical side, folks come to Google when they have a new diagnosis, when they have a question, when they're trying to find where a vaccine is. We launched 5 self-assessment screeners, clinically validated tools that people can do themselves to see where they are. So examples are anxiety, PTSD, post-traumatic stress disorder, postpartum depression, COVID screener. The average person waits 9 years when they have an anxiety disorder like OCD before they share their symptoms with anybody, their primary care doctor, their spouse. I'm washing my hands so they bleed, but I have so much shame around it, I'm not going to tell anyone. Okay, now they can take a self-assessment, completely anonymous, on Google, see where they are, and then we can tee them up with teletherapy. We can help them find an FQHC. We can help them look at their insurance and see where they can get care, get an app, whatever it is. If we can take that 9 years down to 9 minutes or 9 seconds, we think that that platform that we have can really close the gap of people that are suffering to people getting into care. And we all know when you can get to the right level of care quickly, it decreases problems downstream, right? So if you can get easy access to primary care, or if you can get right into the urgent care, or you can do self-care, we know we avoid a lot of the trouble that comes when you make people wait, and then boom, in the night, something goes bad and they show up in the ER and our terrible system of do a lot starts.
So let's take that to the next step. Obviously, EMRs have been a big advance. Those are critical of the traditional EMRs. Would say it's the first progress in technology in our history where you need more humans just to get back to where you were. We're hiring scribes just to get back to the doctor-patient relationship. How do you see Google working with traditional EMRs to improve these healthcare outcomes? And how do you see Google helping to potentiate and be part of that whole predictive analysis of data and interoperability sphere that we're clearly going to need, and something that Mark talks a lot about?
Hey, at Google, we're good at organizing information, right? That's a key thing that Google's good at. So we want to bring that technology into healthcare. So in partnership with Ascension, and we have other partners lined up, what we've done is say, look, the patient you're seeing has 3 or 4 electronic health records that are taken care of. They might be using something in the outpatient setting. They could be 1 or 2 different systems in the inpatient setting. We will normalize that information for you. And then we will present it to the doctor, the nurse, the clinician in a way that's totally intuitive. A Google search bar. So you get called in the middle of the night because you're the hospitalist on call, the patient has GI bleeding. You type into a Google search bar, anemia, melena, you can misspell it. And within a second, all of the information on that individual patient is now presented to you in a way that allows you to take care of them. Are they on any protein pump inhibitors? Are they, what are their normal hemoglobin levels? What are their vital signs? and then help you write the note, help you make sense of it. What we're measuring is, can we get doctors and nurses to spend more time with the patient than at the computer? And right now, all of us have had this experience where you go into the doctor and they say, what was the results of that test? And you know it's at the computer, and you look at them with disbelief. Well, one of the docs at Ascension said to us, I'll build a statue for you if you can find this person's CPAP, a measure of sleep apnea. And we said, well, just type in CPAP, and boom, it comes up from an OCR that was sent in from a fax. So we can take that information on an individual patient and allow that doctor or that nurse to find it in seconds. And that same normalization of data allows us to make predictions on populations, allows us to make predictions about who's going to be readmitted. The EHRs are fantastic because they digitize the record. Now what we need to do is put a layer on top of it that actually makes that useful. And it's useful for an individual, and we got to work on doctors' workflow. And it's also useful when you're managing larger populations.
All right, so Mark, David's got me really excited now that my dream of healthcare at any address, getting care out to where people are going to be potentiated by Google. But on the other hand, I think many years ago, Upton Sinclair said it's hard to get somebody to do something when their salary depends upon them not doing it. So what could an administration with courage do to start to align the payment models with value and outcomes in a way that would make both you and David happy?
Well, I do think the payment models matter. I want to get to that in a second. I also want to pick up on David's point about just how powerful getting the right data paired with the right AI tools can be for improving care. I do want to have a cautionary note there. So lots of data in EMRs. Most of it was designed, to your point, to support billing and delivering particular services when doctors are paid on the basis of delivering more services. So writing down all that detail is intended not just to help, and maybe not even namely to help the patient, but it's designed and organized to support payment. And great that we've got Google tools now that help make it actually useful for integrating data at the person level. There are some cautions there too. If you're not measuring the right data, you can make some big mistakes. There's a good study done last year and the year before by Ziad Obermeyer and some of his colleagues at Berkeley, which basically found that AI intended to help the most severely ill patients was actually aggravating racial disparities because the measure of severity that they were using was intensity of medical care use. So hospital visits, hospital spending, and that turned out to be more correlated with race and barriers to, structural barriers to access for African Americans than it was with actual health status. So you got to measure the right thing. And while EMRs historically have been good for care within the hospital, they often don't include basic information like, what are your living conditions at home? Do you have a safe environment? What zip code are you in? Things like that could really add value. So we got to focus on the data too. And to make all this run, exactly as you said, you'd like to have policies that make the right thing to do, the easy thing to do. So some of those policies include things like data interoperability rules so that people can have confidence that their data coming from different places that can be put together to get them the best care. It's going to be handled securely, and it's going to be handled in a way that's consistent with their wishes, and it's going to be handled reliably. But most important is probably the payment rules and shifting payments so that if what we really want is a usual source of care, a clinician or a team that's trusted by the patient and can help them make the most sense of putting together all of these different apps and tools that are out there that enable them to get more activated in making decisions about their care, more confident, more comfortable in dealing with issues like you said before, or like you all said before about some of the behavioral and mental health issues, getting right connected to a telehealth service to assist them with that. That's not going to happen if we keep only paying for the complications and only paying for the stuff that happens in the hospital. So lots of promising work, and we've seen these models work during the pandemic for primary care groups or integrated care systems that are paid more on the person level, doing a much better job when fee-for-service revenues fell during the shelter in place, and when new models of care needed to be adopted that relied much more on telehealth, that supported things like getting a COVID test into a patient's home, getting that patient referred for therapy quickly if they became ill. None of that's well supported under fee for service. And so hopefully we've got a good tailwind coming out of the pandemic in the US and elsewhere to really move to payment models that support that kind of integrated person-focused care that David's tools can really help enable.
So let me take that. I mean, what I'm hearing a lot of is need for partnership. And in the book that Heyman Taneja and I wrote on healthcare, a manifesto for health assurance, we posited about what would happen if a Silicon Valley entrepreneur and the CEO of a 196-year-old academic medical system walked into a bar, got married, and had a kid. How would Google and a place like Jefferson or Duke, what would that kid look like, where we're actually working together as opposed to just buying apps? David?
So I think we've had that kid. I've been at Google now 2+ years, and I don't come with a strong tech background, right? I come from the same background that you have, Steve, of running large health systems. After being here for 2 years, I am positive that our technology can save lives. It's mind-blowing. I'm also equally positive that if we don't get two things right, the technology will never make it to the light of day. And those two things are, people have to trust us, right? We have to establish trust. And the best way for us to get that trust is through partnerships. So this isn't Google taking care of you. This is Google on an information page saying in the UK, this is what the NHS says, or in the US, this is what Mayo Clinic says, or your Ascension doctor saying to you, this tool is allowing me to take better care of you, or in our partnership with Mayo on radiotherapy for cancer patients. That's the Mayo doctor using our tool. We are not, if we're getting married, you and I, Steve, we are not the caregiver. We need to provide tools to those frontline people so they all have capes on.
Well, this is great. And I couldn't agree more that trust is more important than technology in some way. So I just want to end with this. I like to quote Jason Kidd when he went to the Dallas Mavericks, said, I'm going to turn this team around 360 degrees. We've done a lot of turning things around 360 degrees in healthcare, but just listening to you and watching what both Google have done, what you've done at Duke and CMS, I am really confident that post-COVID, we're not going to be using that quote 4 or 5 years from now. I can't thank you guys enough for being part of this amazing Vatican conference, and we'll look forward to hopefully next year at the Vatican.
Thank you.
We'd like to welcome the former FDA Commissioner, Dr. Scott Gottlieb, who will explore investing in better health and the power of preparedness with CNN's award-winning Chief Medical Correspondent and Neurosurgeon, Dr. Sanjay Gupta, and Dr. Albert Bourla, the Chairman and CEO of Pfizer.
Hello, I'm Dr. Scott Gottlieb here at the International Vatican Conference. The global response to COVID-19 has been accelerated by extraordinary collaboration in data sharing, in research, and in epidemiological surveillance. Joining us here today to talk about how we can improve future response and build on a lot of the collaborations that have been forged in response to COVID-19, and what we can build on learning about preparedness for the future, on vaccine development, on distribution, on issues of surveillance, are Dr. Sanjay Gupta from CNN and Dr. Albert Bourla from Pfizer, where I have the pleasure of serving on the board of directors. It's great to be here with both of you.